Hi, my name is Megan Tarvis, and I'm here to present the case presentation for hypokalemia. Start with a 75-year-old male who was post-op day 2 from a scheduled laparoscopic colorectal resection. Overall he's doing well. He rates the pain 6 out of 10, which increases mobility. The patient remains on clear liquid diet until he passes fletus or a bowel movement. Vital signs are stable at this time. However, the lab called from the morning labs and got a critical result of potassium of 2.5. Patients overall feeling fatigue and weak after waking up in the morning after getting a full night's rest. Patient also reports feeling pins and needles in his hands. Patient has small history of anemia, hypertension, and heart failure. He takes medications daily and monitors his blood pressure at home. Otherwise, his blood pressure isn't usually high, it's normal. Patient has bilateral edema in the lower extremities from the heart failure. Therefore, he takes Lasix twice a day for his heart failure. Also takes metoprolol twice a day and Senna for occasional constipation. Physical findings. There are no physical findings present with hypokalemia. Patients are usually asymptomatic other than if they're feeling tired, fatigue. Sometimes they'll get pins and needles, as I mentioned before, but there are no current physical symptoms. Based on all this information and with the lab result, the diagnosis is the patient has hypokalemia. Patient is at risk for hypokalemia basically post-op after surgery, especially GI. The use of loop diuretics is one of the main risk factors for hypokalemia. Potassium is secreted through excessive urine output through the use of Lasix. A study also found that patients are more at risk for hypokalemia with the GI surgeries, as I mentioned, versus patients being hospitalized regularly. The laparoscopic coloresection requires a bowel preparation, emptying of the bowels, which is done in the pre-op phase. Combination of these two things can cause hypokalemia, especially if there's a lack of potassium in the patient's diet. As I mentioned, the patient's only on clear liquids, therefore no potassium is being intaked. So for the diagnostic test, I would order a basic metabolic panel, make sure all other labs are fine, including potassium. Repeat the labs after this is treated. Obtain an EKG, obviously, to assess for cardiac arrhythmias. Typically, there's an ST depression in the EKG showing hypokalemia. We want to avoid cardiac arrest if there's a prolonged repolarization in the QRST interval. The treatment, as I mentioned, hypokalemia is repleting potassium. This can be given orally or IV. In this case, the patient has a potassium of 2.5, therefore IV might be more effective. We want to assess for phlebitis, with burning around the IV site that can happen with potassium. And we also want to assess for too much potassium, which can cause hyperkalemia with the repletion. So do a repeat EKG after several runs of potassium, as well as patients should be placed on a cardiac monitor to avoid a cardiac arrest. And that is my case study. Thank you for watching.